Welcome, everyone. Thank you for being on time. I'm really excited to kick off the new year with Eva Stahl, who is the Vice President of Public Policy and Program Management. So, Eva, take it from here.
Okay, it's nice to see you all. I'm a little winded because it's like 15 degrees here. So I'm based in Boston. I just went for a walk because I was like, I cannot stay inside all day. So I thought I would start with first just telling you a little bit about me, and then I want to hear about you. And so when we do a round robin, if you can just let me know, I'm just curious if any of you have taken a course on the American healthcare system, because that would just be helpful to me as we walk through some of the material today. I wanted to cover just some of the basics of the healthcare system to make sure that we're all on the same page about how it works. And for some of you, this might be review and you should weigh in, and for others, it might feel new and you should ask questions. So I'm hoping this can be interactive and that you will interrupt me and ask questions as we work through this. And then we're going to talk a little bit about just a basic introduction to social determinants of health and how that kind of plays out in the sort of healthcare setting in relation to medical debt. So why don't I just start by introducing myself? My name is Eva Stahl, and I lead the policy work for the policy and program work for Undo. This is my third year in this position, and I come from a background of healthcare advocacy. So that means that I spent over a decade leading campaigns in states and then also at the federal level to ensure that people have access to health coverage. So that means working with advocates locally and at the state level to advance Medicaid expansion to make sure states adopt it, and thinking at the campaign level about what does it require to solve that problem. So working across different stakeholders, hospitals, politicians, insurers, community health workers, anybody in the space that cares about those things, figuring out how to organize people on the ground. So making sure that patients' voices are heard and that they're being organized at the right moment during the campaign to create pressure to advance decisions that reach that policy solution. So that's the work that I come from. And I have a PhD in health policy and a master's of public policy. So I started my career actually thinking about law school, as many people that do policy work do, and then decided I would rather write laws than practice them. So that led me to do the policy work, which I did at UT Austin, and then ended up doing my PhD at Brandeis. There's a place called the Heller School that focuses on health policy. Yeah, that's just a little bit about me. I have 3 children, and 2 are at home, one's working, and one is in high school. And then my middle child is actually in Maine, where he's a freshman. So, and he is studying environmental science. So that's me. So Dina, maybe I'll hand it off to you to help me kind of just do the round robin, and I can hear a little bit about people's aspirations and backgrounds, as well as you can give me a little bit of a just sort of a test on where you are in your knowledge about this stuff.
So, just going off of the pitch that I guess we were made the assignment, but my name is Claire and I go to UC Berkeley and I study public health. And then I got interested in this fellowship because I was super interested about like the US healthcare system and health policy and health equity. I thought this would be a great way to pursue that. And then a fun fact about me is I have 2 dogs. And then I'll pass it to Zainab.
Hi, my name is Zainab Zafar. I'm from New York and I'm a junior at the Wheatley High School. And I'm interested in either pursuing medicine or art history. And I joined this fellowship to learn more about our healthcare system, spread awareness, and then educate others and educate others on ways where we can help. And then a fun fact about me is that I could speak Chinese. I've been learning it for a couple years outside of school, and I'm self-studying for the AP Chinese exam right now. And Ariana, do you want to go?
Hello, I'm Ariana. I am originally from Queens, New York, but I'm tuning in from the University of Buffalo, where I go to school. I'm studying public health on a pre-medical track, and I decided to participate in this fellowship because I'm always looking for ways to merge public health and medicine. And I think doing this program was definitely one of the ways to do so, just to learn more about medical debt and being a future healthcare professional. I think it's very important for someone like myself to be very educated on something like this going into healthcare. So yeah, and I'm enjoying it so far. Um, I will pass it on to Jay.
Sounds good. Thanks, Ariana. So my name's Jay Bell. I'm from West Des Moines, Iowa, originally, which is the west of the capital city of Iowa. I go to Iowa State, which is 45 minutes north of where I grew up. I'm a sophomore in industrial engineering. I joined industrial engineering because I originally was going to go to school for writing and had a full ride, but decided I wanted to do stuff with more technically. So I switched into that, which was kind of a risk because then I had to pay for college. I am really passionate about healthcare, and I want to make a difference in the kind of work that I do. Right now, I'm a safety engineer at a electrical power plant that does that kind of thing. And a large thing we talk about is healthcare and preventing injuries and stuff. So it'd be good to get on both sides of that. Plus, I want to raise money as well, and so this is a good opportunity to help me get more information about doing that and get me into in connection with the people that are really good at that. A fun fact about me is that I am skiing today, and I skied today, and in the 3 hours that I skied, I saved 2 people that were hurt, and I had to call them in because they were beginners that didn't know what they were doing. Yeah, there's a certain group of people. It's Texans. No, that's what they always say. They seem to get hurt quite often, so that's a fun little thing that I've been doing.
And we have some Texans in this group. Hey.
Hey, it's nothing against Texas. It's just their skiing ability. No, I like Texas a lot. All right, I'm gonna switch it off to Tripura if you would be willing.
Well, that's so funny because I am Texan, so that's just a great way to pass it off. I'm Tripura. I am a junior and I go to school at University of Texas at Dallas. And I don't know if people know University of Texas at Austin, and just like a sister school near my place. And I am a neuroscience major that's on the pre-med track, and I'm also taking a gap year. And I think what got me interested in this fellowship is I knew someone that already was in it, like Galila, who couldn't be here today, but she like passed it on, like she passed a message on. And I was like, this is very interesting because I did a summer mission trip in India where we went and helped give free basic medical care to like low to like poverty level incomes over there. And then it just got me really interested because then I could see and understand what happens in the United States and just like our healthcare system, because I think that I am severely lacking in education and awareness in that to myself, and just educating myself and the people around me. And I think that is everyone.
That's great. So, but before I jump in, does anyone have any questions for me? None yet? Okay, we'll get there. Trust me, because it gets weedy pretty fast. Yes, Jay.
I was wondering if you had a reaction to today's news out of the White House with the credit bureau, because I was reading that this morning.
I actually did a couple media interviews about that today. So we're thrilled because we've actually been working on shifting that policy over the past couple of years. So for those who might not be familiar, the Consumer Financial Protection Bureau, so it's called the CFPB, it's an agency it's at the federal level. It was actually an agency that was birthed out of a financial crisis with the banks, which you probably don't remember, which is a good thing. But this agency is really tasked with protecting consumers from credit schemes and different things related to debt collectors. So it's around what we call fair debt collection practices. And they released a final rule today that pretty much says that medical debt will not show up on your credit reports. So is everybody kind of familiar with, like, I'm sure that you've heard at least from friends or family, like, oh, you need to start building a good credit record, right? So often, like when kids go to college, it's like, take a credit, like get your first credit card, use it on things that you're always going to pay on time because you want to build a good credit history. And that's because when you miss a bill or something like that, it goes on a credit report. There are 3 large credit agencies in the United States. They're called TransUnion, Equifax. Oh, what's the third one?
Experian.
They're Experian. Thank you. Yeah, it's so funny. We actually use them. So Experian, and they are non-governmental, but they do actually track and keep track of people's ability to pay bills on time. Right. So if you owe money or you take out a loan, it shows up on that credit report. So if you apply to buy a car, for example, they're going to pull up that credit report and see every place that you missed a bill, you borrowed money, or you didn't pay a debt. And so what the federal government said today was that medical debts specifically, so unpaid medical bills that you couldn't pay, will not show up on that credit report and harm your credit history. So we're super excited about that. We spent a lot of energy advocating for that change. So what that looks like is making sure that when we hear from our constituents after we relieve their debt, they tell us their stories. So we'll go back to them and say, can we submit your story to the federal government to sort of give an illustration of why putting medical debt on people's credit reports is so harmful. So, someone might have cancer and then they no longer have access to credit. It means they can't buy a car, they can't get a job, they can't rent a house, right? So it's really important for people's opportunity and their future health. So yeah, it was a really big day today. We're super excited to see that change. Now, the other thing to think about is because it's what we call an administrative action, which means that it's an action taken outside of legislative process. It's what we call administrative, that a new administration could change that decision. So what everyone is sort of weighing in on today and wondering is, will the Trump administration uphold and keep this final rule, or will it claw it back? We call that the clawback. So it's still in a window of time. There's something called, what is it? It's like the Congressional Reduction Act, where a new administration can pull back regulations and rules that have been implemented within, like, so many days. So this actually falls in that window. So if the Trump administration wants to repeal it, they can. Our hope is that there will be so much public support for this change that it would be kind of politically unsavvy to pull back. So we'll see what happens.
That's good. Oh, sorry.
Zainab had the same question. She's always first on these calls. So Zainab, is this clear now? Good.
Yeah.
Jay, you can keep going. Sorry.
Yeah, I was just curious because, Trump talked a lot on the campaign trail about pulling back regulations from, they said,
Yeah.
the current administration.
Yeah.
I'd be curious if there was something proactive that we could try to do to make it so that he separates the two things, this being like the popular ones and the ones that are
Right.
going to go to the people that are supporting him. I mean, I don't know.
And I think that, I mean, you have the right thinking, because that's often what we call strategic communications. So it's thinking about, how do we know what Trump values? And we know that the populist arguments and populist platforms where, for the people tends to be, I speak for the people, kind of the mantra. So, feeding into that language and doing Facebook ads and thinking about elevating those stories of relief for people, that they don't have to worry about that anymore, will be super important over the coming weeks. And I think you'll see a lot of advocacy groups take out ads, elevate stories, remind individuals to call their legislators and remind them how helpful and good that this action is for their communities. Because the flip side of it, right, is you're going to hear from bankers that think that medical debt should be on a credit report because they feel like that they don't know something about an individual that takes out a loan. And you're also going to hear from providers where physicians and hospitals are worried that people won't pay their bills. So it then becomes a war of narrative, right? And it's less about policy and it's more about politics. So it's just part of the trajectory of the work.
Thank you.
Sure. Any other questions about that or anything else? I can answer anything, but you can interrupt me the entire time. So why don't I share my screen? And we can walk through a little bit of these slides I put together, which is, let's see.
And really don't be shy. Eva is the champion of ask questions. So you're all really welcome to just jump in whenever.
You are, and I'm also a talker, so feel free to interrupt me. How does that look? Can you guys see that? Okay, looks good. So I was just talking to Dina about like, let's just do a quick recap. And I think about just insurance and the landscape and how this all works. And we'll can stop in the middle too, just to talk a little bit about how we do our work. So my job is less about abolishing debt, right? Which is the main work of the organization. It's a function, it's like a service, right? We are a service organization that works to identify medical debt that's out in the debt sphere, right? So that could be with hospitals, that could be with a primary care physician or a specialist that might have unpaid medical bills. And we approach them and we ask to purchase that debt so that we can just get rid of it. We also do it with something called the secondary debt market, which Sandy talked about, is when, it goes through the whole billing process and then they sell it to a debt buyer. That's a whole market, so we'll often buy it there. And we can talk more about that, but my job is actually listening to constituents. So once we do that debt relief, what are their stories? What are they telling us? What's the problem we want to solve for them? And it's really important to put them at the center and listen to what they're saying to us. And so that's really what drives the policy work that I do. So it drives the conversations that I seek to have with policymakers, and it helps me think about, if somebody says my biggest problem is high out-of-pocket costs, which is actually the number one thing we hear from our constituents, which means that I have insurance, but all the costs associated with that insurance, like the copay when I go to the doctor and the bill that I get after, which we can talk about some of this terminology, like those are the things that are my pain points. Those are the things I can't afford. So for me, I'm thinking a lot about how do I solve that problem. So I also want to go back and let's just step back and talk about medical debt in general, like who experiences it. So this is a chart that's drawn from data from the census, and it tells you a little bit about income level. So you can see the blue is the lowest income folks. The middle is the sort of orange yellow color, and then green are the higher income folks. And you can see that like the middle class is really getting hit hard with medical debt. And part of that is because the lowest income folks typically have access to some type of financial support. So whether that's through insurance program in their state called Medicaid, which not all states have. Texas is my pain point. So, right, but other states do have a Medicaid program, which is for lower income folks. And then middle class folks often face a little bit of a cliff, right? So once Medicaid stops, then there's an expectation that you purchase your own insurance. You either get it through your employer or you get it through what we call the marketplace, which is the Affordable Care Act. So it's an open market, but it's a marketplace where you go shop around and you get like a coupon. It's called a subsidy based on your income to purchase coverage. The problem is that coverage can still have high costs associated with it. And we'll talk a little bit about that. But this gives you a little bit of a sense of who's experienced medical debt based on income and based on age, right? So it's also interesting just to see how 65 plus, those bars kind of drop down. That's Medicare. So that's the program that supports people in our country over the age of 65 and is universal, by the way. So then you look at folks that are really feeling that have past due bills, which is a proxy measure for medical debt, right? If you're not paying your medical bills, that you either have medical debt or you're getting close to it. And I just wanted you to see where young people fit in there. And actually, you can't quite see it, but you see up on the legend where it says 24. So that's actually 18 to 24. And I don't know why that got blocked out, but it did. So the 18 to 24 is this blue right here, the sort of more royal blue. So it just gives you a sense of like who really has unpaid medical bills. And if the answer is yes, and you look across those age groups, like that's not insignificant that young people have unpaid medical bills. That's a really early part of your life to be carrying debt, right? So it's just important to remember, like 18 to 24-year-olds in that blue block is pretty significant. Like you're not that far off from folks that are entering kind of the professional parts of their life where they have an income and starting to think about families. Okay. So let's talk a little bit about any questions about sort of the data landscape about who's carrying medical debt. So, I mean, I think the main points of that is like, this is a middle class problem. It definitely affects lower income people, but it also is increasingly a middle class problem. And that 18 to 24-year-olds are not protected from this, right? This is something that is a growing problem. And for folks in your age group, it's something that you should be cognizant of and concerned about. Okay. So I wanted to just spend a little time talking about the insurance landscape because you all might be less familiar with it. And it's a crap load of acronyms and it's super confusing. But I just wanted you to sit with it for a second and just ask me questions if you have it. So as I mentioned before, you needed health insurance, right? Everybody needs health insurance. When you're a kid, you get it through your parent. Because of the Affordable Care Act, you can access health insurance through your parents through the age of 26, right? This is like the greatest gift ever. Just remember that as long as your parents will include you in their insurance till you're 26, one, you should take it. And two, it's incredibly important for people in their early 20s in particular to make sure that they have access to coverage. So your parents most likely are getting their coverage through their employer. And if they're not, then they're going to purchase their coverage, right? Or they're going to be uninsured. There's still the option to be uninsured, right? And this is something that that really is a stressor for a lot of people, particularly lower income workers. And that's because if you get your coverage through your employer, there are fewer guardrails around what that insurance covers and how much you have to pay. It is the way that it's really designed historically is that it's set up as part of like your benefits package. So when you get a job, they'll tell you you have this great benefits package that includes your income, right? Your salary. Oh, and it also includes this amazing healthcare package. And they view that cost associated with it as a part of your total benefit. And so that's how, employers often will compete, right? Who has the better benefit package for recruiting talent? So, but for very low income people or low income workers, so there was a report out, I think earlier this year that looked at Walmart workers that are making lower income, lower salaries, right? So low that they qualify for public insurance. They qualify for Medicaid, right? So it's just, there are different pathways and different opportunities, but it's an inequitable system. So other ways that people can access insurance would be through the Medicaid program. This is a state-federal partnership, which means that the federal government pays a portion of it. The state puts up a part of it. That is dependent on how wealthy that state is. It's called a federal match rate. It's based on demographics and various different variables. But that's what we call a partnership program, the Medicaid program. Medicare is a federal program. That's for people over 65. And then there can be older people that are low income enough to qualify for both the state Medicaid program and Medicare, the older adult program, right? And those people we call duals. So let me just pause there and see if there are any questions around the pathways for getting insurance. Because I know it can be a little bit confusing. And if it's like, Eva, I already know this stuff, you should also tell me that too. But the employer-sponsored insurance piece is private insurance, right? This is a private market, to be clear. And then the marketplace plans afforded through the ACA, the Affordable Care Act, those are also private plans, right? So the only public insurance coverage, which means that the government funds funds most of it, all government dollars, is Medicaid run by the state and Medicare run by the federal government. Okay. So, and then I put on there too, you'll see TRICARE. So veterans do have a special place in our system, and they do have access to coverage through a veterans program, which is sort of rife with its own issues. So once you sort of think about the doorway to get your insurance, there are different types of insurance you can purchase. And often the types of plans that you can get are what we call, there's the HMO, with a health maintenance organization. There's a PPO, which is a preferred provider organization, and then the EPO, which I think is like an exclusive provider organization. And this pretty much means like, what are your, like how much flexibility do you have in your insurance plan? So if you join an HMO, it usually means that you're being cost conscious, and it means that the insurance product says to you, Jay, you can only access these 10 providers, and you have to get permission from your primary care provider if you want to see a dermatologist. And if you can't agree to that, then you will have to pay full price. We won't cover that. So it's very stringent rules. So you have to be super careful, and you have to be comfortable being in what we call a very tight network. But the benefit of that is that you're going to pay less money because they're keeping a really tight control on you. So say say somebody else they want more flexibility, right? And they want to be able to choose and think a little bit about, who they see when they want to see it. So Tripura decides, I might want to be in a PPO because I don't want to have to talk to my primary care physician if I want to go see my mental health provider, or if I want to see, an ear, nose, and throat doctor, right? Like, I don't want to go through a gateway. I want to be able to see who I want to see, and I want a broader network. So you're going to pay more for that, right? You're going to pay a higher premium, and that's because the network is bigger. So there's less control. So part of it is as a consumer of healthcare, which we don't really like using that word. We often say patient, but you have to be smart about what do you want? What flexibility do you want? And you have to balance that with how much you're willing to pay. Now, the other sort of plan design, this is what we call plan or benefit design, that's really important to think about, is that's just about your network access and who's giving you permission to access the healthcare you need. There's also a design of how you pay, right? So every month you pay a premium, right? That's like $120 every month. I'm going to pay a premium for insurance, whether I use it or not. That's what I'm paying. Who knows what a deductible is? You can yell it out. Jay says he knows. Yell it out, Jay.
Oh, sorry. I think it's the amount of money you have to pay before the insurance will cover the rest of the cost.
Well done, Claire. That's exactly right. So the deductible is really important when you're choosing health insurance. And this is where people get trapped, because increasingly there's an effort to reduce the cost of health insurance, particularly for employers, right? Like, they don't want to pay all that money for health insurance for people, right? Because it's going to mess with where they would rather invest in operations. So one way to reduce the cost of health coverage is to increase the deductible, because it means, Claire, that you're on the hook for $5,000 before the insurance even kicks in. So that's a super important number. And that's where people are getting tripped up right now, because more and more that employers in particular only offering people what we call high deductible plans. And that plan design can be really harmful for people that make $28,000, $30,000 a year. They don't have $5,000 lying around, right? They're barely making ends meet. Maybe they're working 2 jobs. So that's really challenging for people. And then there are 2 other pieces of this. One is called a co-insurance, and one is called a copay. And a copay is part of the benefit design that says every time you go to the therapist, it's $25, which, by the way, is stupid. But, right? So think about how that adds up. And that doesn't go toward your deductible, Claire. So that's not going to help you chip away at that $5,000 obligation. So the other piece of it is called coinsurance. And coinsurance, if I could get rid of one thing, I would get rid of coinsurance. And that's because it's a percentage of your visit. So my son broke his arm. He goes to the emergency room, so he's in the hospital. It's that when they do the bill for me, they tell me this is how much the insurer negotiated to pay with the hospital you used. This is the amount that they agreed and contracted to pay the physician. And this is 20% of the bill that now you're responsible for, right? Do you think I knew how much that was going to cost when he broke his arm? I had no idea. Did I have a choice? No. So it might be $5,000. And by the time we get down to the contracted rate, it might be $1,400, but I still owe 20% of it. So that's called coinsurance. And what I hate about coinsurance is that you are blind, right? You have no idea how much these things are going to cost. And so it's just important to understand what your coinsurance is too, because even though you might have met your deductible, in some benefit designs, you'll still be paying the coinsurance and the copay until you meet your out-of-pocket maximum, which is the last piece of this. So we have the premium we pay every month. We have the deductible that we have to meet before insurance helps us. We have the co-pays that we have to pay when we walk through the door. We have the co-insurance that is attached to any hospital visit, which is a percentage of responsibility. And then on top of that, there's another number called the out-of-pocket maximum. So for example, my current healthcare plan, we have a $5,000 deductible for our family and a $7,000 out-of-pocket maximum. So that means when together we've met that deductible, that's one hurdle. And then the second hurdle is to get the spending up to when we meet $7,000, then we stop paying. So, right, that's when they finally cap where we don't have to pay anymore and we pay zero. And often pharmacy will be a separate piece of this. So the benefit design will have a set of deductible and copay and coinsurance for the healthcare services. And then often they'll have a separate sort of out-of-pocket maximum and copay structure for your pharmaceuticals. So I know
And
there's a lot.
lab work.
Yeah, so that's a lot. So let me pause for a minute and just see if there are any questions.
Is the reason for separating them so that if you have one area where you really like stack up, then it doesn't allow you to spill over and your benefit doesn't spill over into the next area between like lab work and care?
Yeah, I mean, it's a scheme, right? To make sure that you're paying more money,
I have a
essentially.
question.
Yeah.
So let's say like it was a really bad year, you had an accident and you basically maxed out everything. Do
Yep.
they like start increasing your like monthly like premium package after that? Like let's say you like paid how much ever you could from your pocket and then they're
Mhm.
paying the rest and then next year do they like increase that based on like your past performance and
Like
stuff?
car insurance?
Yeah.
Yeah. So they're not supposed to, right? Because you're part of a larger risk pool. And it is something where we could see fraud occur, but it is something that it shouldn't affect what we call your rating, right? And so when insurance products, when they build their rate system, like when they build the how much this is going to cost, they use something called actuarial analysis. So they're looking at all of the past claims for an employer. Maybe an employer has 3,000 employees. So the employer is actually carrying the risk for all those 3,000 employees. So if in total everybody had an accident and the healthcare costs went up, then the insurer would say to the employer in the next year, like, we're going to have to increase your rates for everyone. So they tend to prefer to be pooled. So that's how they determine risk. And that goes back to how do we deal with the risk of insurance? So does everybody understand the concept of risk? And so generally it means, right, with any insurance product, the idea is we all pay in, and then if somebody gets hurt, we can deal with the stress of that. We can pay it out, right? But that we're all sort of collectively protected. So the problem is if you're right, if you have a bad year, then you're going to raise rates on the employer the next year. If you have multiple people within a firm that have high healthcare costs, right? I remember when I first got married, my husband's mother had a tragic sort of incident and she was hospitalized and she worked at a small, she and her husband worked at a small private school and they felt terrible because that next year everybody's premiums doubled. So, the goal from the employer, right, is to make sure that they're making a decision about their healthcare coverage that can better protect people. So if you're a small firm, you might not decide to cover your employees to bear that risk. You might actually choose to go out into the marketplace to spread the risk across, like by sort of combining with other small businesses or firms. And that gets to how is risk managed, those bullets right there. So when we talk about risk, when an employer, like a big employer, like, I don't know, what's a big employer? Like Dell, your Texas. So say Dell, Dell most likely runs its own health insurance. What this means is that they take on the risk themselves and they hire something, a healthcare company like United Healthcare. And United Healthcare just administers their health insurance. But Dell makes the decisions itself about what they're going to cover, what services they're not going to cover, what some of the exclusions are, right? They're making all those decisions around the benefits. Whether or not you have access to a big network or a small network, the employer makes that decision. So that's called self-insured. That's when the employer is carrying the risk. Fully insured would mean that I'm a small employer of 20 employees. I don't want to take on the risk. That doesn't sound good. So I'm going to go shop in the marketplace with the United Healthcare and just have them give me a plan, and then they take on the risk. Those plans and that pathway is more expensive for people. And that's often why big firms like to self-insure and take on the risk themselves. So those are kinds of the ways that we mix and match how we take on risk. But they're very technical and complicated. So I think the big takeaways are, how do we get health insurance in this country, right? We get it through our employer. We get it through the government, through Medicaid or through Medicare, and for Medicaid, it's based on your income. For Medicare, it's based on your age. Or we get it through the marketplace, which is the Affordable Care Act marketplace, where you can buy healthcare plans and the government will give you a little bit of a coupon, a subsidy, to help you buy that plan if you earn less than 250% of the federal poverty level in this country. So that's meant to kind of layer on top of the Medicaid system. The problem is, as many of you know, and Tripura, you know really well living in Texas, is that we have states that have chosen to not expand Medicaid. And so what that does is it leaves a huge swath of the population either uninsured or paying very high healthcare bills, or both, right? Because they have no coverage. The number one way to mitigate the harm of medical debt and avoid it is to have health insurance. Even though we know health insurance isn't perfect and we know it's still leaving people with medical debt, it still is incredibly important to be insured, right? And the more knowledge you have and the more you know about how health insurance works, the more you can make better decisions for yourself and the people you love to make sure that they're protected. I spend half an afternoon every year with an Excel sheet, and I look at all of my healthcare bills from the year before, and I try to predict how much we're going to spend in the year next based on how much we paid and what those rates the insurer paid to providers, to give myself a sense of, you know, how much money we have to save and put away to be able to pay that $5,000 deductible. It's ridiculous. I mean, and it's still challenging and frustrating, and I have a PhD in health policy. Like, that's just, it's ridiculous, right? It's just not how it should work, but that's how it works. All right, everybody feel good about their pathways to health insurance? And we can go deep in any one of these. They're complicated, but it's meant just to give you a working sort of vocabulary and understanding of how this landscape works. But the people that are most at risk, as you saw from the data point in the first slide, are middle-class people. Unless you live in a state that has an expanded Medicaid, and then it goes all the way down to zero, the people that are at risk. And most of them are working people that don't have what we call an offer of insurance, which means that they're working low-income jobs and their employer doesn't even offer insurance at all. And they have no money to pay for it. So that's another issue. Okay. We talked about this a little bit. High deductible health plans. So when we listen to our storytellers tell us about their experiences with medical debt, this is what we hear. It's like people that thought they had good insurance. They just bought something thinking that, you know, it would work for them, and then it didn't, right? And usually it's because they have very high deductibles. So if you're earning, you know, let's be honest, like if you live in Boston, like I think if you want to keep the lights on, you've got to make $65,000 a year. That's how high the cost of living is here. So that's pretty rough. And that's still, you know, 400% of poverty is about, you know, 400% of the federal poverty level is about earning about $100,000 for a family of three. And those are the people that we help. So, you know, a lot of these service employees and these types of jobs are earning anywhere from $20,000 to $70,000, right? And they're at risk. So you can see a little bit about how, you know, to bring the cost of healthcare down for employers, they tend to offer these high deductible plans, because what it does is it shifts most of the cost onto people. The employer's like, I can't deal with this. This is so expensive. Like, I'll help you out a little bit, but you're going to have to take some responsibility for what you use in healthcare, and therefore you're going to have to carry a high deductible. So, and that gives you a little bit of ideas of like what these deductibles are for people too. All right, any questions about that?
I have a question.
Yeah.
So for the high deductible plans, is it also like the employer like pulls everyone and they give them the base price, being like this is going to be the high deductible, or can you negotiate it when you like first get the job and that's like in your benefit like plan? Can you like negotiate the high deductible plan or no?
You can't, because what usually happens, and typically when you start a job, they might have, if you're lucky, you'll have 2 or 3 plans to choose from. So the employer would say, look, we've signed contracts with an HMO, and we've signed a contract with a PPO high deductible. So part of like when I told you I did that Excel sheet, it's looking at what are the plans that my husband's work offers, and I run the numbers for each plan to see what the costs are. So something like a high deductible health plan, you know, you could pay $120 a month for your premium. And if you go to a PPO that has no high deductible, it goes up to $900 a month. Like that's a big difference, right? So part of it is you're taking a gamble on like, how much healthcare am I going to use? And do I want to just sort of rely on the fact that maybe I'll dig into my savings to pay that, or do I want to pay it up front and then just not worry about it? And often those decisions are very personal, right? Do I have diabetes? Do I have a family member with heart disease? Do I have a child with asthma? Those are all things that I know require repeated visits throughout the year to stay healthy. So I would probably shy away from something like a high deductible health plan that is really, you know, you're rolling the dice a little bit. But what happens is when you walk through the door with a new job, they're probably going to put 3 plans in front of you, and then you have to make a decision for yourself about which one fits your needs. But they have negotiated every year, they negotiate with the insurer to build out that benefits plan. And they have contracted set rates with physicians. So they've already negotiated all of those. So that's not something that you can actually negotiate. Does that make
I was
sense?
g- um I was gonna ask, so like your employer's plan, right? They supply you with a health insurance plan. Does that always cover your children, or does it not always cover your children?
Not always. Yeah.
Okay,
So sometimes you have to pay more. So like if you, it could be offered to an individual, a worker, and then if you want to add your family, then the prices will change if they even offer you an option to add your family. So many employers will just cover you.
sure. So if you have health insurance and you have an employer that is willing to provide for your family as well, is it usually that you just pay a little more and it's everybody, or is it you have to go per person? Because I could see
It's
a scenario where you add a person with 7 kids, all with congenital heart failure, and
right,
that like that school, but like that school example where
right.
it was very limited in size in the risk pool, so that would blow up the risk for everyone else.
Yeah, it's interesting. I mean, usually there can be different price points for like a couple and or a partnership, right? Or marriage, and then a different price point for a household. But I've not seen that the household is limited. It's a good question, Jay, and I don't know the answer. I just think it, and I can look into it, but I think that typically there's just a price for a household, right? And I think, you know, it's, you know, depending on the state you're in or you know, what your background is, like typically it's smaller than 7 kids, but you know, my dad's 1 of 9, so I shouldn't speak out of turn. Any other questions? Okay, so this is just a little bit of a reminder, and I just, now that you kind of have a refresher or a first time glance at like how you access insurance, you know, I want to just sort of revisit a little bit about the way we think about insurance in this country in terms of who we help. So in many ways, the Affordable Care Act was intended to fill holes. So if most people get their health insurance through their employers, right, there's still a cohort of people that don't have access through smaller employers, or they make a low income, right, and they can't afford their health insurance offer from their employer, right? And so really the people that are most at risk traditionally are up to 4 times the federal poverty level. So the way the Affordable Care Act was designed, which I actually worked on, is that people below 138% of the federal poverty level should have access to Medicaid. So in its original form, it was supposed to be a seamless sort of coverage ladder. So from 0 to 138% of the federal poverty level, states would give you access to Medicaid benefits, which are very robust, actually, right? Because when we think about and look at the public health data, people at low incomes also tend to have what we call more comorbidities, which means that they have more health issues, right? And that often can come from generational poverty and from generational racism that we know affects people's health and well-being. So then above 138% of the federal poverty level, people have access to marketplace plans. So when you move from a Medicaid plan, which is pretty robust and includes a lot of benefits, and when I say that, it means that if you are a low-income person on Medicaid in Massachusetts, your transportation to and from the doctor is covered by Medicaid. So those are additional what we call wraparound benefits that are super important for lower income people. And then once you hit that next level, which is what we call the Affordable Care Act coverage, which are the ACA or Obamacare plans, those are offered in the marketplace. So from 100 to 400% of the federal poverty level, people can shop for a private plan. These plans don't have the wraparound benefits of Medicaid, even though these individuals and families might need them, but they do offer subsidies that are on a scale. So from 100% of poverty to 400, there's a scale with how much money the federal government will give to help you subsidize the purchase of a private plan. Right? So this is like buying an HMO or PPO. So in the same way that you might get a new job and choose a plan from your employer, people are going onto the marketplace and they're choosing an HMO, PPO. They're having to understand benefit design. Think about how complicated that is. And they're like having to choose from 30 different plans and make that decision for themselves. And they also know that the federal government might give them, $100 a month to put toward that premium. So after that, when you get up to 400% of the federal poverty level, there really are no more supports. So it means that you really have to get your health insurance through your employer or buy it independently, and you buy private coverage until you reach the age of 65. And then you have access to Medicare, which is taken out of your payroll taxes. So when you get a paycheck, you can look and see in your paycheck how much money is taken out to go towards Social Security and toward Medicare. It's what we call a universal program. Everybody has access to it. You pay into it, you get it. It's very popular, right? But it is also still expensive. So people on Medicare get hospital care, but they actually have to buy an additional plan if they want to get care outside the hospital. We call that supplemental. And it can be quite expensive. So that can be a hardship for older people. But for the most part, Medicare folks have good access to health insurance, even though it might be expensive for some of them. And almost every physician, provider, hospital takes Medicare. So your network is like everyone. So those are the different layers of health coverage. So understanding those layers, this is the design of our program. So we know that people that hit 400% of federal poverty level, they don't have any options, right? Above that, but we know that they're in a better financial position, and we know that there's precarity for people below 400% of poverty. So we really target people, regardless of insurance, who might be carrying unpaid medical bills and medical debt, to make sure that we're helping that target population. The other folks that we help are when their medical bills are more than 5% of their income. So those would be folks that have like a serious cancer event, right? Or open heart surgery, right? Like something really massive that is so expensive and it eats up more than 5% of their total income, even though they might be earning 500% of the federal poverty level. So let me just pause there and see if that makes sense. I just wanted you to understand the insurance landscape and why we design our program the way that we do.
I guess I had a question on the process of how Undo, I guess, buys back the debt. I know that we went over this in an earlier session, I think, but
It's
I'm just a
always
little
worth reviewing. It's so complicated.
But I'm a little bit confused on how much information like the hospital or insurance company provides when they're selling the debt. Like you said, you have to meet the two qualifiers, but how much, like, do you know that only those two qualifiers, or is there other information you know about the debt?
Sure. So this will give you a little bit, you can see kind of where we intervene. So, you can sort of look at that while I answer that question, Claire. So it is complicated, but what we do, we have a set of data that we ask let's start with the situation of we approach a hospital. We want to purchase what we call their bad debt. So that means that it's an unpaid medical bill. They've tried to collect on that medical bill and they've given up. And so they've put it into, think about accounting books, right? If you are, an accountant and you have an unpaid medical bill, that's a loss for your business, right? So you kind of just shove it in that column to take the loss. We call that bad debt. So what we do is we look at that column on a hospital's accounting book and we say, we want to buy all that bad debt. You've given up on collecting it. You're not going to get paid. Let us buy it. And here are all the data points we need about that debt in order to buy it. So we have a set of data elements that we ask for, and it usually runs the gamut of like the person's name, the amount of their healthcare bill. Sometimes we get a diagnosis code. It's not required. Their zip code, their most recent address, their age, some of their demographic information, right? And once we collect all those data points, they send us a file. And we have something we call the debt engine. So we have a bunch of mathematicians and programmers that are our data, that we call them our IS team. And they have built something called the data engine, which allows us to bring in all of those data elements from the hospital, right, in a cybersecurity safe way, because as you can imagine, this is also what we call personal health information, PHI. And so we have to be very careful. We're all actually HIPAA trained. So, and we can talk about what HIPAA is later, but it's making sure we do a safe transport of that data onto our data engine. And then what our data engine does is it applies an algorithm. So what this means is that in order to meet those two criteria to know if we can buy those files, we have to know if that person is earning below 400% of poverty, so earning household income below 100 grand, or if their medical bills in total, they might have multiple medical bills, if those medical bills add up to more than 5% of their income. So in some, Claire, like we need an estimate of their income, right? And we're not going to get that from the hospital file. So what we do is we work with a third party to build an algorithm that makes an estimate of that person's income. And it's based on multiple different data points that are publicly available. It is crazy how much data is out there about you, but it's out there. And so they draw on things like, what is the average income in your zip code? Where is your address? What are your buying patterns? Right? What state do you live in? What are your demographics? What is your credit history? All of those different data points go into an algorithm to make an estimate, a range to give us an estimate of what you make. If that range falls into our criteria, we buy the file. And we only buy files for people that meet that criteria. And then once we purchase them, then we own them, right? So essentially, no one will ever have to pay them. It takes us time to push out those letters, but that's when after we send the letters. So that, say, for example, we get a hospital file and 85, we call it qualification, 85% of those files qualify for our program. So we're going to purchase all 85%, and then we actually return the ones that don't qualify. So, but all of it's based on income estimation, so we can see if they meet our criteria. And then once they do, then we build out the letters, we mail them to people, and they have a QR code on the letter where they could come back to us and tell us their story.
Okay, that
So
makes a lot more sense.
It's kind of wild, right? And so if we did that through the secondary debt market, so we buy debt in multiple ways. We buy debt from hospitals. We buy debt from like a physician group, which would look very much the same. So one thing we didn't really talk about, which Sandy probably lifted up, is when you go to the hospital, you're going to get a hospital bill. That's different than the physician bill. You're going to get more than one bill.
Mhm.
That's what's confusing for patients, right? You get hospital bills, and then which sort of is about the infrastructure of the hospital, providing that space and that service to you. And then you get a bill from maybe the anesthesiologist, and you get a bill from the surgeon, right? You're going to get different bills from the physician practices. So we buy debt from those physician practices and the hospital. Sometimes we can group them together, sometimes we can't. And then the third place we buy debt would be from what we call the debt market, the secondary debt market. And that's debt where a hospital decided when it had a bunch of bad debt, it sold it to a debt buyer. And that debt buyer restarts the debt collection process. So those people are very much at risk at being harassed. And it tends to be older. But part of why we started buying hospital and physician debt was to get younger debt. So our debt now is on average of 18 months to 2 years old instead of 5 to 7 years old, which is what it usually is on the secondary market.
Okay. Yeah. I guess at a follow-up, would you say the qualifications that they need to qualify for the program would encompass middle class people who have medical debt, or is
Yes.
it mostly lower class people?
I would say that the average debtor is somewhere between 175% of the poverty to 275% of the poverty level. So it's kind of hangs in the middle. And as you can imagine, if we work in a state like Texas, we have a huge amount of people that are going to be under 150% of the federal poverty level. Versus when we work in a state like Massachusetts, we have more people that are clustered up closer to 400% of poverty.
Okay, thank you.
I
I
see
had a
Michael joined us. Michael, can you mute yourself? Thank
I'm
you.
sorry, my bad.
You're good. Jay,
I-
you had a question. Oh, go
Yeah,
ahead, Tripper.
Well,
Go,
Jay can
Trevor,
go
go
first. He
first.
had
Go
it
first.
before.
Okay, I was just gonna ask, so if you buy we buy one of these packaged omnibus debt collections. Let's
Yep.
say 90% get or qualify and 10% don't. Obviously,
Yeah.
the 90% makes sense based on that way you've laid it out. But the 10%, do we give it back free of charge?
We don't buy it until we qualify it.
Okay, so it's
So
so
we
you
ask
just
that
shave it from the package.
exactly.
Okay,
And then we
okay.
price the package based on the qualification. And the pricing is based on the going rate for debt, right? We don't negotiate price. We just tell them this is the going rate based on the age of the debt and what's happening in the debt market. And this is what we're going to pay you. And it's usually about a penny on the dollar.
Sure. Do we have is there somewhere you can look at it like a graph of what the going rate for debt is?
I can look
Like
and
an exchange rate?
the best place probably to look, I can ask Ruth, our debt ops lead. She runs all of the hospital purchasing, but I'll ask her. But I think another good place to look and resource that I can share with you is out of the Consumer Financial Protection Bureau. They've published just a number of really good papers and really digestible, easy to understand papers on medical debt and also just about the debt market. So what's interesting about this issue is that debt collectors as a business tend to be small businesses and mom and pop shops. So, even though they're cast as the bad guy, right? They're also pitched as small businesses, which is a little bit more of the political dynamic of you're down on small business if you're against debt collectors, but it usually can't quite play out that well because, if you're in the debt collection business, people usually think you're not great. So, but it depends. But there's all kinds of debt collection, right? It's kind of like the rule that we always tell people, if you have an unpaid medical bill, don't put it on your credit card because you just lost all your protections from medical debt. It's now financial debt. So, you've got debt collectors that are hounding people for credit card debt as well as medical debt, all kinds of debt, right? But they do tend to be sort of small mom and pop shops. So often hospitals will have, they'll have 30 small business contracts with debt collectors, and they'll just roll out people's unpaid medical bills to these debt collectors and give them 6 months to try and collect on it. And then the debt collector never owns it. They're just they're renting it to try to collect on it. And then they get paid a fee for every amount that they can collect on. And then they return those files to the hospital. So it's a whole fascinating industry in itself. Tripura, you had a question.
Yeah, so this could be like maybe something that you're gonna explain later, but or something that we've already talked about, but like where do you have the resources to get like to pay these like to buy these debts?
To buy debt first. So
Yeah.
we are so incredibly lucky. Do you remember this woman? Her name's Mackenzie Scott. Does that ring a bell with you guys? So she's the ex-wife of Jeff Bezos, and she has a tremendous amount of money. And as a part of what she has decided to do with her life is to give it all away. And so she gives gifts often to the nonprofit sector. Like the YMCA got a lot of money, Planned Parenthood got a lot of money. She's given us, we've gotten 3 gifts from her. To-
130.
is that where we're at?
Yeah.
$130 million. I just love the look on your face. Yeah,
Yeah.
yeah,
And
I know.
also, Tripra, we've been very, very lucky with incredible donors and a lot of people who love the model in the sense that $1 relieves $100. It can be around less, more, but it just excites people so much that they
Yeah,
love
it's a good
donating
return
to
on
us.
investment. Yeah. And so it just draws a lot of different types of donors that you might not typically have. And we always say everybody can be a philanthropist because everybody can raise money and do this. And even governments have obviously gotten into it over the past couple of years. So we have over 20 government contracts where, like the state of Illinois, state of Arizona, state of New Jersey, we did DC, Rhode Island, Connecticut. It's spreading where states want to throw money at this to help sort of relieve debt for people. And I think it also acknowledges and that medical debt relief is it's kind of, it's in the moment and it's direct relief and it's now. And that can be quite meaningful to people, both financially, but also really emotionally. And for us, we really hope people are returning to care. So, like the announcement today, we hope will help people return to care if they don't have to be fearful about their credit report being ruined for getting the care that they need. And I also think that, part of my job too is building what we call the narrative. So it's making sure that we're engaging with the media and having conversations about medical debt so it just never leaves the spotlight. And what we're doing is we're creating pressure on decision makers to feel the heat, and they need to feel the heat to solve the problem. And so part of it too is thinking about, how do we solve this problem? What are the solutions and what are the incremental policy changes that we need to make that can sort of help build momentum to get us there when we know that, a lot of people feel like you need to burn it all down and have a single payer system. And that might be true, but there's no political will for that. And so when you don't have political will, what are some of the steps you can take to build yourself towards your North Star of making sure everybody has access?
That's like
So
wonderful.
go ahead, Dina.
Just two things. One is it's 6:08. So I'm just giving
Okay.
us a time
I don't
of
want to steal your group time, so you
no,
tell me when to
no.
be quiet.
I think this is just so valuable, and you can nod your heads, guys, if you feel that way, right? Because Eva, you're just a well of knowledge. I wanted to ask one question regarding the credit cards. So I think everybody heard this in multiple sessions. Don't put your healthcare expenses on credit cards because then
Yep,
it's not medical debt.
it's no longer medical debt.
The question I have is about healthcare credit cards.
Oh, sure, those are different. So medical credit cards are a bit of a different beast. So when you go into, and they're most common actually, for who has 2 dogs? Was it Claire that has 2 dogs? I have 2 dogs too. If you go to the veterinarian, it's super popular. And if you go to the dentist, it's super popular. So, like, for example, my kid got braces. We always tell him he has a $5,000 smile. And it's because when you walk through the door, right, that's what braces cost, but you don't have that lying around. So they said, oh, we're going to put you on a payment plan. It's a medical credit card. So what they're doing is building up, they're telling you, look, you have 2.5 years to pay this off. And sometimes they don't tell you that, but you have 2.5 years to pay this off. And then the interest rate's zero until you hit that 2.5 years, and then it goes up to 25%. So those are some of the tricks of these medical credit cards, which people need to be very wary of. And they're increasingly showing up in hospital settings. in addition to dental and veterinarian. So the Consumer Financial Protection Bureau is both also, if it continues to kind of exist, it will continue its work on these medical credit cards, which are troubling, right? Because they're ways for hospitals to get paid immediately. And then the debt shifts to the credit card company and no longer the hospital. But the hospital is going to be a better negotiator and more compassionate and has a mission to serve you in a different way than a credit card company. So if you're ever in trouble with a bill you can't pay, you go to the hospital and you try to negotiate before you try to do any other kind of, particularly a medical credit card. And they tend to be really bad actors. Synchronicity is one, and there's one called Care. What's it called? Care something. Anyway, but they're kind of infamous, and they're not good products. I would not recommend them. So, but they're a little bit different than just whipping out your Visa and saying, I'm going to put this copay on there, which, you know, if you have the money, you might feel secure doing that. But if you have a large expense that's a medical bill, like you had a procedure, say you had like a mole removed at the dermatologist and the bill is $380, then maybe you want to think twice about putting that on your credit card. Maybe you want to think about coming up with a payment approach. The other thing you can run into too is with specialists that they might say to you, we want to keep your credit card on file. You have the right to say no. And they'll look at you funny, and that's fine. But you have the right to say no. I just want to get bills and I'll pay them. But you don't need to keep my credit card on file. So that tends to be a new trend too, because I think that, increasingly people are getting nervous. They're not going to get paid. And so a lot of physician practices and hospitals are looking for ways to kind of sneakily get themselves paid and shift that burden onto the patient, which is unfortunate. So this medical debt patient journey is just to give you a little bit of idea. So we talked today a lot about what are the pathways to coverage, right? And selecting your insurance to protect yourself so that you can access care. You want to be able to walk into a doctor's office and have an insurance card and know and have some certainty that that care will be covered, right? Then you're going to get a medical bill that will be based on that benefit structure that we talked about deductibles, co-pays, co-insurance. And we can actually send you a medical debt 101, Dina, remind me, with a huge glossary with all these terms. And then you can't pay that bill. What do? You ignore them. You shove those bills in your drawer. You get panicked. Your heart races. You don't know what to do. You just ignore them. And then you're going to start to get phone calls because after so many bills are sent, usually 3, they're going to send you to collections. And those collectors don't own the debt. They're actually just borrowing it from the hospital. And they're making phone calls and trying to harass you and get you to pay those bills within a certain period of time. And then say you can't really pay still and you ignore those calls, you don't pick up the phone. And if you're smart, you still keep a landline and you never answer it, right? And then you get to the point where there is a debt sale because the hospital's like, I give up. You're not going to pay your bill. I'm frustrated. I'm just going to sell this bad debt because there's a market for it. And the reason there's a market for it is because a debt buyer will buy it and they'll say, hey, we're going to try again. We're going to try collections again. And they're going to analyze your credit history and they're going to pick and choose who looks the most likely to actually pay me. And they're going to try to set you up with a payment plan with a high interest rate and get you to pay so you'll stop being harassed. And in some cases, you might even be taken to the point of bankruptcy. Medical debt is still the #1 source of bankruptcy for Americans. Any questions about that journey? But you can see where we intervene. And part of that is required by federal law, just so that you all know. There's an Office of the Inspector General. It's called OIG. It's part of the federal government that sort of like does oversight. And there's a law called the Anti-Kickback Statute. And this means that, doctors can't do things to benefit their own financial well-being. So like if you own an MRI or an X-ray center, you can't like refer all your patients there so that you're making profit. That would, because you're getting a kickback from that referral. Does that make sense? And so that's called the anti-kickback statute. So we had to, as an organization, had to get permission from the federal government to be able to buy from hospitals so that it wouldn't be seen as a kickback. And part of that is because we're paying such little money and we're replicating what already occurs with the debt market that we've been given that permission. But what it does require is that we can't intervene until reasonable efforts have been made to collect on those unpaid medical bills. Hopefully that makes sense. Okay. All right, any more questions before we kick into the next topic? I hope that was helpful. It's a lot of information, and you should just sort of keep notes on questions that you have, and we can always revisit them. Like, just because I'm not on the, the next session, or Lindsay, I think, is coming up on the next session, but we're always available to kind of answer questions for you all. Okay. So I wanted to talk just really quickly and close us out with this concept of social determinants. So is everybody familiar with what this is? Do they know what it means? Does anybody want to take a stab at it?
Can I try?
Yeah.
So it's everything in your life that would affect the outcome or the likelihood that you would take on medical debt, which sort of, if you pull it back a step, is how likely you are to get sick, right? So if you can't afford preventative care, if the area you live in doesn't have access, you don't have access to clean water, whether it's like Flint, Michigan with lead issues, or if you aren't aware because you've never been educated from the school system about what to look for in diseases, like not common knowledge about which arm it is for the heart attack thing, that can be very dangerous, right? So that was my take.
That is right. And it's kind of like we always used to say, where you work, where you live, where you pray, usually determines your health more than anything else.
Okay.
And so
Eva?
when you go, yeah,
I think Ariana also wants to take a stab. Am I right?
Yeah, I was just going to say that it was, or to put it in simple terms, like the non-medical factors that determine your health outcome.
absolutely. You got it. And those things matter, right? Like, it matters where you live, unfortunately, in this country. And there's this whole project that first lifted up this concept out of the University of Wisconsin called County Health Rankings, if you haven't heard of it. And it sort of maps out social determinants by county across the country. So, you can often predict how healthy a community is, right, by looking at some of the factors, the non-medical factors, as Ariana says, or, the water access, the food access. Do you have what we call food deserts, which means that you're buying your groceries at 7-Eleven instead of a grocery store, right? So it's just, those are all of the pieces that really matter for people's health. And, medical debt is considered a social determinant of health in the sense that, it affects how healthy people are, right? Because if you have medical debt, you're less likely to go to the doctor. You're less likely to seek the care that you need. You're more likely to avoid visits, and you're more likely to have mental health distress and anxiety. So those are all things that we know affect your health and well-being, that tie back to medical debt. So that's often how we talk and think about it. So this is another great resource, if you don't know it, is Kaiser Family Foundation. And an arm of that is called Kaiser Health News, KHN. And they, have you all seen the whole reporting called Diagnosis Debt?
No.
Maybe not. We'll have to put it in the chat for you guys, or I'll link it to you. But there's a guy there who's a friend of ours. His name is Noam Levy. He's a journalist, and he has done extensive reporting on medical debt over the past couple of years. And we work really hard together to kind of, elevate the media narrative around medical debt to make sure people continue talking about it. Anyway, so the Kaiser, so he leads the Kaiser Health News part, which does all the reporting. And then the Kaiser Family Foundation does research. So if you're interested in health policy, if you're interested in health data, and also just understanding, they have actually a really fabulous whole Health Policy 101 series I can send to you, which walks you through the whole history, like everything we walk through, like the history of Medicaid, the history of Medicare, how subsidies work, how insurance works. So it's really a great tutorial, but this is one of their sort of infographic images on social determinants. And you'll see that medical bills is on there around economic stability, right? So where the whole health system has been moving, particularly over the past like 5+ years, and I think for people that are interested in becoming physicians in particular, that these issues are becoming increasingly important to understand. So it means that you're having conversations with your patients, not just about their health issues, but about the non-medical factors in their life that might be exacerbating or leading to health issues, right? And that is a huge responsibility and huge increase in scope of work for physicians. And it can be overwhelming and lead to burnout. There was a study that came out today, actually, that said that the more you talk about social determinants with patients as a physician, the more likely you are to burn out. And what that says to us is that physicians need more support, right? They need teams of people and they need other types of providers on those teams to help patients deal with these non-medical issues, because physicians don't go to school, right, to solve problems on housing. That's where, advocates and social workers went to school to do, right? So it's about building a better system that matches up those different team members to help people with social determinants. And so at the end of the Biden administration, I would say, they really invested in that concept of social determinants, screening for them, but also making sure they were supporting community partners. There's this huge body of research that's super interesting that looks at how much we invest in healthcare financially from a budget perspective, like a state and federal budget, and how much we invest in social services. And healthcare eclipses social services. But in countries that invest more in social services, which are like the non-medical pieces, they have better health outcomes. Right. So it's kind of fascinating to think that, it's a very American thing to be investing downstream instead of doing prevention, which is, I think, one of the lessons that we're learning as a part of our sort of exploration of social determinants. So this is just a little bit of just gives you kind of some bullets on what the research says, just so you know the research behind social determinants, and why it sort of has come to light and become a focus around the issue of medical debt. And I would say the biggest study is this one by Himmelstein, who's actually in New York, and is a big proponent and leader in sort of the public health space around the issue of insurance and health. And you can see that that there are these risk factors, right? When you have medical debt, you're more likely to be food insecure, right? And you're more likely to be unable to pay your rent or lose your ability to pay utilities or be evicted, right? Those are really important correlations and effects that become an important part of the narrative and why we want to solve the problem. But let me pause there. And then we can send you these slides too. And all of these are hyperlinks on the last slide for you. So you can see kind of all of the medical debt 101 would be a really good place to start. But let me stop sharing for a second and see if you guys have, if you have questions, because I know that was a lot tonight. It's a lot to digest. And if you take a course, right? So that was the other thing. So if you have the opportunity to take a course on the American healthcare system, I would highly recommend it. Because it's whack and it's just so much to learn, but it's also, you can see how incredibly complicated it is. I've spent, 2 decades trying to understand this system and I still don't fully understand it. So, because it is so incredibly complicated, but I think for the purposes of being able to navigate it, everybody needs to know a little bit of something about insurance to make sure that they can protect themselves.
I see digestion.
I know it's a lot to process. It's a lot to process. And I would also just say, are there more things that you want to know about or things that stumped you that you want to dig deeper into? Because I think that Dina and I would both love to know that. And then if I can be helpful or, in diving a little deeper or sharing some resources with you, I'm happy to do that. And you should all make sure you linked in with me too, as well. That's just a good practice.
I think, let me see. I can also launch our poll and you can write your takeaways and just if there's anything else that you want to learn about. And if anything comes after the session, you'll be like,
Yeah.
just write it down, send it in an email. We love learning from you, right? And your questions are going to be what your age group wants to probably know and learn and needs to learn about. And I hope this is starting to form, right? Because our goal is to create some kind of a awareness campaign, or we'll discuss that afterwards, but that really allows your communities to access the bullet point information of what you're learning from the different people. So Eva, thank you so much. I mean,
No, I know it's like drinking from a fire hose. The other offer I would make to you too is that, I know you're all in different states and every state is different. And so if you want to know a little bit more about your state, just let me know. And I'm happy to, drop you an email with a link so that you can kind of take a little bit of a deeper dive into what your state actually looks like. Because they all are structured a little bit different. So we have this joke where we say, if you've seen one Medicaid program, you've seen one Medicaid program, because there is a lot of flexibility in how to design your Medicaid program in your state. But I would say that Medicaid is such an important anchor in states to help people, right? It's and we're still not giving up on states that have yet to expand. So we'll get there. North Carolina just did it, so. So often in every state, they'll have insurance navigators. So these are folks that get grants from the federal government to help people shop for insurance. And so those are the folks that know the most about insurance. So if you ever get into a position where you need to purchase your own insurance, navigators are really a great resource for that. But they often will use those tables every year to help you understand whether or not you qualify for subsidy and support. And I think part of it too, I would just say lastly, which is a really big part of this, is to reduce the stigma around this. This is an impossible system. It is a ridiculously expensive system. Just because you need subsidy, support, or help, it doesn't mean it's no character judgment on you, except that the system is broken, right? People are working multiple jobs. People are trying really hard to make this work, and it doesn't work for them. And so I think it's really important to continue to remind people this is not a handout. This is like a cluster. And so you should sort of be smart about trying to pick up any resource and help that you can get. And until you can change the system, you play the system as best as you know how to protect yourself and your family. That's my challenge to you.
I had a quick question that just
Yeah.
popped in my head. I understand that, let's say that we do come across this resource being undue medical debt, but I understand that for most of the part you guys buy from hospitals or physicians. Is there any chance that we can come to you and be like, can you guys review my income and everything? Do you guys think you guys can relieve this debt for me? We come to you.
Yeah, we don't do that. I mean, I think it would be so incredibly complicated and we'd be so overwhelmed, Tripura, that we couldn't do it that way. And part of the beauty that keeps the return on investment and the administrative costs low to do this work is to do it in bulk, right? Which is, I mean, that's essentially why and that's why we also go to hospitals more than once. So we might buy a portfolio of debt last year, and then we go back and say, okay, go back to your bad debt files so that we can continue to do what we call cleanup, right? And we want to continue to clean up until the laws get better. So now that we have this change in the credit reporting, maybe it will get better for people, but we won't be able to know that for a couple of years when we hopefully see the data change. All right, Dina, are you good?
I always learn something. It's just amazing how and also that's part of the system, right? It keeps changing. There's always something to learn. I'm grateful. I want to thank everyone for participating, and you, Eva, for feeding us, right?
No, and I know it's a lot, so I apologize if it was too much, but I would also just say, connect with me. Let us know if you have additional questions. I have to run and pick up a kid, but I'm open to to communication, and I'm really excited to meet you all and excited to sort of see what you guys are interested in and where you want to take this work. So I'm really grateful for the opportunity.
So just I'm letting you know that one of the assignments every session brings is to connect on LinkedIn with the speaker. So expect to connect with everyone on LinkedIn.
I will.
And before, right?
That was very informational.
Eva is she's my direct boss, and I just keep learning from her all the time. And everyone asked great questions. So I shared the projects, like the project suggestions with Eva, who's my boss, and with our social media manager, Emily. And everyone is pretty excited about what your thought process is. And what we were thinking is actually a combination of the two. So with running a social media campaign might be harder than creating an informative video to distribute in colleges. So what we were thinking was, and please, please, please feel free to jump in. This is like open discussion. But what we were thinking is we could do is almost a combo of the two. Start thinking about what would be a good informative video. Like, what does a young person need to know in terms of what do I do in case of medical debt, right? There's what do I need to do in case of medical emergency? I hope everybody knows, right? Like call 911, go to the ER, like right? But what do you do in case of medical billing or medical debt? So I think even from today, right? Don't put your medical debt on a credit card. So starting to do this, and as we're creating this information, we can think in two channels. One is, how can we do this as a social media campaign? Maybe it would be called like things you need to know about medical debt, and what would be important information that young people, or let's say a freshman in college, when I don't know what is the process for onboarding these days into college. So, right? So we could work on both channels. How do you feel about it?
I think it's great.
Tripura, I was thinking of you because I don't know what's the verdict regarding TikTok.
I don't know. Actually, TikTok might be like something that we have to put on hold because they said that they were thinking of making it like banned in the United States, and then Trump is like maybe not. I just don't know the whole thing. I have to do my research on that, but definitely we could do like Instagram and YouTube for sure. And I think I would like love to have like um definitely Eva and the other people that work and have the data to like come up with like certain things that like people should like never do, like I think I heard it before and definitely today was emphasized a lot, like never put your medical debt on credit card, like just like simple things like these that might just seem very like, oh well, that just sounds the most plausible, putting like something that I have to pay for on a credit card, like I would have thought of that. So I'm just saying, like, people do think of that stuff. So, like, just like simple, basic tips that we can put in videos. So, like, I would love to like reach out to them and just get like a very like things that they see people do wrong all the time that should not be happening because it's like a very easy fix that they could have done before.
Okay, that sounds awesome. And would you be, first of all, who's camera shy? Who doesn't want to be on camera? Because Jay, you're camera shy. I think it would be very powerful if parts of the messaging is delivered by you, who are students, who, if you're showing it to your community, are going to be recognized by your community. Like, here's something I care about. Here's something no one should feel ashamed of, right? Like, we have all these, like, the number one concern is that people don't go back to seek medical care when they have medical debt, right? So it's really important that people understand that there's resources, that there's things to do, that care is very important. Any other thoughts? Like, first of all, are you still digesting what Eva was talking about? Is there anything you want to ask? Like, did you get enough of social determinants of health? Did you learn something new, or do you still feel like it was a lot of information and you just need a moment?
Well, with all the
No.
information, I'd be curious to say the what the consensus is on what is the most important stuff to emphasize in the awareness, right? Because we obviously could go into a lot of math and a lot of like, debt buying layering, but I don't think that's going to be very engaging.
So why don't we just go around and see what are you guys getting so far? Because I think that is, you are the leaders in a way, right? What is one thing that you think, Jay, is in the sense of raising awareness to the medical debt issue for people your age?
I would say probably explaining the nuances of the plan so that you can get and how it works so that you don't go in completely blind and then you don't have to make all the mistakes. So trying to preempt the mistakes that people will make. So the credit card thing, not putting things on credit card, um, you know, picking plans with, realizing what a deductible is and how that will affect you, right? And these are concepts that can be, Iman has a great comment there. Seek low deductibles, yeah, exactly, and that kind of thing, and figuring out what makes the most sense, and getting into a group that's risk diverse, so you're not affected too much by any one thing, like that kind of.
Great. Thank you, Jay. So basically what we learned, a lot of what we learned today, right? What are basic terms and basic, almost like 101. What do you need to understand about health insurance? And that, right, that simple explanation is going to make a big difference for a lot of people. I'm going around, and if you feel like I'm calling on you and you're not ready to answer, just say I'm not ready. Don't. Okay, so Claire, do you have thoughts of what are already things that you think can raise awareness to the issue?
Yeah, I think, well, definitely going off what Jay said about like explaining the nuances of the different plans so people know what they're going to get themselves into and kind of what plan might work best for their situation. And then I guess we could talk about maybe like or emphasizing the importance of getting insurance. So I think what was mentioned today was like not having insurance is the biggest risk of actually getting medical debt. And maybe people don't realize that because they don't realize the risks it could be in. So talking about that maybe.
Thank you. Ariana, how about yourself?
I definitely second Jay's opinion on going over basic like mistakes. I feel like people who enter like who are just beginning like their healthcare journey are young people. So just like getting them those facts early on.
Mm,
I think it's also very important, the basics of health insurance, or even like going over like how health insurance would help you like avoid high medical bills in the future, or um I don't know, just like I guess pretty much what the group was saying, like pretty much simple things that you might think is obvious, but it's not as obvious as you think it is. I think that's
yeah.
very important to like stress when it comes to insurance because it's a big picture is very complicated, but you have to break it apart and like go into step by step, detail by detail to like get it right. So
Yeah. So thank you. And also I like what you said. So there's, right, explaining the plans, and then having insurance, like not having insurance is the biggest risk of medical debt. And then you're saying facts. You can say 1 in 4 young adults has medical debt. Like this is, can you, right? We can do like statistics, like just fun, right? Fun facts, fun, I'm saying, but there's
yeah,
a
for
lot of
sure.
right? A lot of information that if people see the numbers, they'll be like, oh, wow, you know, there are people around me that probably have medical debt. And Tripra, do you want to say any, like you said, simple, basic tips? I wrote never should you ever, but like a never should you ever kind of a session with some of maybe Undo's professionals. Like here's one tip from our policy person, here's one tip from our hospital relations, here's one tip from our information systems, right? Do you have
Yeah.
anything to add to that?
I think like just like having the tips from each like department, like one or two tips, and then having like what everyone says, like basic like definitions explained. And like I loved Eva's session because she kind of like broke it down and she like did the pathways and everything. And I personally thought like I could really understand. And so I think if we kind of just like replicate that to like make like the maybe like the example something that we're all like relate, just like making it really relatable so everyone can understand. I think that would just be like perfect.
Awesome. And I know Ayman, if you want to add something, Michael, I don't know if you're capable of texting, please do. Like everything can be saved. Zainab, how about yourself? What so I'm just gonna say something because Zainab is already on her. I don't know how many campaigns have you run before.
This is like my second or third.
Okay. So, and you've probably helped
Yeah.
your sibling.
Mhm.
So, what do you think is something important, or how do you see raising awareness to the issue of medical debt with the knowledge you're starting to accumulate?
Well, first off, like what everyone was saying, like we should first share tips on how to prevent medical debt and then like methods, how to manage costs, and then simpler terms and then more concise so that they're able to understand health insurance, like how you were saying with the three like bold words, how they that's what they take away. And then also because we're focusing on like the youth, which is like 18 to 24-year-olds or something, but how they're affected the most by medical debt. And so we could also provide solutions for them.
Awesome, thanks. And I think the biggest group is between 25 and 36.
Oh, okay.
It's okay. Listen, one day you're 24 and the next day you're 25, right? It's statistically that's how it shows up. And I believe that a lot of the people in that group actually carry over the debt from the past. And also this is when people actually start families. This is when people want to buy first-time homes, right? So if you have a medical emergency and you end up having medical debt, that really puts a block or a hurdle between you and adulting, right?
Mhm. Yeah.
I see. Thank you, Ayman. Shedding light on the timeline and stressing the importance of not paying right away nor putting medical debt on credit cards. That's excellent, Ayman, right? Because you do not, like what Eva was saying, if someone wants to have your credit card on file in the hospital or in a clinic, you have the right to say no, and right? Knowing your rights makes a big difference. I think we're making a lot of progress. I feel like you're starting to really get a, a good grasp on what we're doing at Undo and what kind of knowledge you're getting and that you can share. How am I correct in that assessment? So, and this is what we want. We want to build your confidence in talking about this. So what do we want? Our next session, because we are approaching the very end, right, of today. Our next session is January 21st. And that, let's see. And we may actually, we were supposed to have Lindsay next time, who's the policy analyst at Undue Medical Debt. And she will probably be on a business trip, so we'll have another working session next in 2 weeks, right? The 21st is in 2 weeks. So I think that gives us a lot of good an opportunity to actually work on the project. So as usual, I'm wondering, how are you leaving this session? Oh, Zainab, I'll start with you and pass the baton.
It was very enlightening. I felt like I learned a lot about health insurance, which I would not have learned. Like in school, we don't learn about this at all, or anything helpful, really. And then I learned a lot about different types of plans, which I thought was interesting. So yeah. Tipura.
I think I would say very just like informative too, like because I learned a lot. Because again, we don't really learn this in school, and I haven't taken that many classes on healthcare in in the United States. So I think I'm gonna pass it on to Jay.
I'm feeling really good. It was obviously a hard day, so it was nice to get away from that. So I really think that we have some ideas that can work, and try to find people in spaces that for our project that will make sure that they see it and get information on it, and I think that'd be a good thing. Oh shoot, Claire.
Okay, I feel like I'm feeling pretty excited for the project. Today was super interesting, and I think definitely helps solidify like the information that we've gained so far, and I'm excited to see where the project will take us. And then I'll call on Ariana.
Yeah, I believe today was very informative. Like I work in healthcare as like a medical assistant, so I think it's very interesting to see like how insurance works from the patient side. Um, so yeah, this made me really excited like to get into the project because I feel like now that like we're all kind of like more informed on like what insurance is like, I think we're now heading into like a really good direction with this. So I'm excited.
Iman, if you want to write it down, oh, okay, I see. Shocked by the preventative rates of medical debt on both younger adults and the middle class, in addition to the lower class. Michael, are you able to put your takeaway from today?
Yeah, I can talk. I thought it was interesting about how all the other factors that go into somebody getting medical debt, like a lot of social factors that are kind of harder to see in statistics. I thought that was very insightful. Thanks.
Awesome, thank you. So, it is 7 o'clock in New York, and it's time for us to close up. I really want to thank you all for showing up, for asking and engaging with Eva, and I could really see you thinking, right? It was a lot to process. Thank you very much. You're welcome, Ayman. I'm looking forward to seeing you, Claire, on Thursday. Have a good night.